Good evening, everyone. A very warm welcome to the faculty of this evening and all the participants from across India and from other parts of the world. We already have more than 350 registrations, and we do hope that about 200 people would be joining the program this evening. At the very outset, I thank Indian Oncology Foundation and Mice Ideas, led by Rajesh, for creating this platform, and which is powered by Samarth Pharmaceuticals, conceptualized by them amongst the series of programs, and this is the second in that order. We still have a couple of more programs coming up later this year, but the focus in today's program would be the GU cancers on the prostate, non-prostate, and of course, looking at the third lecture on the single versus the dual therapy. Friends, over the last decade and a half, a lot of things have happened in the arena of the GU and oncology. Medical oncologists did not have a significant share in the treatment of these cancers till about 2005 and 6, when docetaxel was approved for prostate cancer. And the story has unfolded very quickly. We know that the targeted drugs, immune checkpoint inhibitors, and the integration of chemo and radiation in the neoadjuvant setting has really opened up the horizon. Not only that, the maintenance therapy with the immune checkpoint inhibitors is a new horizon, giving a better overall survival to our patients. And not to forget that many more therapies in the space of prostate cancer have come up in the last 5 to 10 years. ADT chemotherapy continue to be part of the armamentarium. Anti-androgens have opened up the therapy space, lutetium therapy recently, and also the immune checkpoint inhibitors and the dendritic cell therapy. Also, not to forget that the HRR-based and the BRCA testing in prostate cancer has gained traction with the advent of the PARP inhibitors as well. I don't want to take the thunder away from the presentations. And with that little introductory opening remarks, I hand over the proceedings back to Rajesh ji for you to continue with the first speaker and thereon. I thank everyone once again who have found time to join the program, and let's hope over the next about 90 minutes, 75 to 90 minutes, it would be a great learning experience for all of us. Thank you so much. Over to you, Rajesh.
Thank you very much, sir. Now I invite Dr. Tanmay Mandal. Dr. Tanmay Mandal is consultant medical oncology and hematology from Kolkata. He at TMA, and he will be taking care of Genito urinary cancers, prostate. Over to you, Dr. Tanmay.
So if anyone can put my slides from the sponsor side, I think you have the slides. You send the slides basically.
Nirav, please share his slides.
Sir, I did not receive the slides from Dr. Tanmay, the final edit version.
You share the original version.
Okay, no problem, sir.
Is it ready with you, or you want me to share?
Yes, it is ready, sir. It is ready.
Okay.
Tanmay, sir, can you see the slides?
Yes, I can see the slides.
Yeah, go ahead, sir.
Okay, so good evening, everyone. So I'm Dr. Tanmay. So I will be presenting on the advances in prostate cancer as per it was the highlights in the ESMO Congress this year in 2022, which was I think a month back. So next slide, please. Next slide, please. So yes, as this is a master class, so the slides which were kept into this place were mainly taken from this ESMO Congress only, because most of the things were the advances which we have in this era, in this field, was presented in this year's ESMO at present. So for that only we kept these slides into the in place so that it becomes a good lesson for us. So comes the what are the advancements in the treatment landscape of this prostate cancer, advanced prostate cancer, from the locally advanced to the hormone sensitive, and then comes the castration CRPC or the castration resistant. We have the multiple trials, the radical CSD trial, the Peace One trial, which came, the Propel and the Keylink 010 trials. These are the trials which were this evolutionized in this era of the in the management of this. We have the use of the dual or the triple drugs or the triple agents which we use now. So these are, have also come into the place. So next slide, please. So background, around 20 to 25, 25 to 50% of the patients with clinically localized prostate cancer will develop a biochemical recurrence after a radical prostatectomy. The risk factors for relapse after a radical prostatectomy includes if it's an R plus resection, if it's a high Gleason score in the range of 8 to 10, if it's a T3 or a T4 disease, and if it's a node positive disease. So these are the groups of the patient, or these are the risk factors which tells that these patients are at a higher risk of relapse. So the strategies for treating them are, one is an adjuvant radiation in these patients high risk groups. We need an adjuvant radiation, or another thing is we keep them on monitoring and plan for an early salvage radiation in case of a PSA rise, or if it's an early PSA doubling time, if we see, then also we can plan for a early salvage radiation or a salvage radiation to see. So in case of salvage radiation, systemic hormonal therapy can be considered. 4 to 6 months of ADT antigen deprivation therapy. It has been seen that it improves the biochemical and the clinical progression-free survival. And 2 years of bicalutamide also, as per the RTOG trial, it has been seen that it has improved the metastatic free survival and the overall survival also. Next slide, please. So this is the radicals design, the trial design, eligible radicals design, the post prostatectomy patients with. So the radiation timing, what we did is that either it was an early radiation post surgery, or it was a deferred radiation. That means when there was a doubling of the PSA, or if it's a PSA failure, then only deferred radiation it was planned. So these were the two randomization arms, and hormone duration and randomization also, either in the radiotherapy alone or radiotherapy plus 6 months of hormonal therapy, and radiotherapy with 12 months of 2 years of hormonal therapy. So next slide, please. So this is the randomization chart which we had. Next slide, please. So the inclusion and the exclusion criteria due for the post-op radiation after radical prostatectomy for adenocarcinoma, either as an early or as a salvage, either as an adjuvant or as an early salvage radiation. And exclusion criteria is that prior pelvic RT if the patient has received, or if the patient has been received prior hormonal therapy, if the patient has a metastatic disease, or if the PSA is more than 5, then they are excluded. They were excluded from the trial. Next slide, please. So the primary endpoint of 0 versus 6 months of hormonal therapy, what we saw that if the patient has not received any hormonal therapy, or 6 months of hormonal therapy, the metastatic free survival, which was with RT alone and with 6 months of hormonal therapy, the 10-year event-free survival was 79% in the RT alone arm, and 80% in the RT plus 6 months of hormonal therapy arm. So there was not that much significant benefit. Next slide, please. So, slides, I think, went off. So Okay. So the take-home message in this Radicals HD trial was 6 months of hormone therapy versus no hormonal therapy did not meaningfully improve the metastatic-free survival, whereas 24 months or 2 years of hormonal therapy versus 6 months of hormonal therapy improved the metastatic survival with an absolute benefit of 6% at 10 years, with no overall survival benefit in either approach. So what we came to know from this was the metastatic free survival was benefited if the patient received a longer course or a 2 years of hormonal therapy. Additional information was also overall survival benefit was seen. Next slide, please. So the take-home message from this adjuvant versus the early salvage therapy is that adjuvant radiation may be indicated in patients after radical prostatectomy with node negative features. If there are two or more high risk features like the grade 4 or 5, if it's a PT3, T4 disease, or if it's a margin positive case, consider for these patients only early adjuvant therapy might be indicated, or it was beneficial. And for hormonal therapy, of course, 2 years of hormonal therapy was seen to be benefited in most of the patients. Next slide, please. So salvage radiation or early salvage radiation in the era of ultra-sensitive PSA or a PSA doubling time to access the PSMA PET CT. So early salvage radiation in case of confirmed and rising PSA in particular in high-risk patients, that means the patients in which the PSA doubling time was less than 1 year, and if it was a grade 4 or grade 5, then we considered a PSMA PET imaging if the PSA is more than 0.2, if the result influences the treatment decision, but not wait for the PSA threshold to initiate the radiation. Next slide, please. So this was the earlier slide only. Next slide, please. So next comes the Stampede trial or the study design. This we know, it is an old study design. Next slide, please. So the overall survival in metastatic disease only in M1 disease was that the hazard risk ratio with a doublet and a triplet, what we see that the standard of care plus abiraterone plus enzalutamide versus the standard of care plus abiraterone, the p-value was not that much significant. Next slide, please. So next comes the PEACE-1 trial, PSA at 8 months. PEACE-1 means addition of abiraterone and plus prednisolone to ADT plus minus docetaxel improved the overall survival in men with synchronous metastatic hormone sensitive prostate cancer in the PEACE-1 phase 3 trial. The 6 to 8 month PSA decline to undetectable levels has been associated with an improved overall survival and radiological progression-free survival in other metastatic hormone sensitive phase 3 trials. So next slide, please. So overall survival according to 8 months PSA doublet versus the triplet, what we saw that 8 months PSA, if it was less than 0.2 and if it was greater than 0.2, it was significant with a p-value of 0.007, and so 51% in the triplet received the 51% achieved a PSA of less than 0.2. Next slide, please. So in which patients synchronous metastatic hormone sensitive that are chemotherapy fit, do you recommend the triplet therapy ADT plus docetaxel plus an androgen receptor inhibitor? So in majority of the patients, independent of the disease volume, only in high volume patients. So what we see that in most of the patients, only in high volume patients, it had much amount of the most of the voting. It was a voting method, and during the conference it was done, and most of the doctors supported that option 2, which is that in the high volume patients, we prefer the use of chemotherapy. If the patient is chemotherapy fit, we prefer the use of a docetaxel plus an androgen receptor pathway inhibitor. Next slide, please. So the take-home message from the Stampede and the PEACE-1 trial is that the long long-term follow-up confirms the benefit of addition of abiraterone plus ADT, that endocrine triplet ADT plus enzalutamide does not improve the outcomes, overall survival or metastatic-free survival, but results in additional toxicity. So in the PIECE-1 also, 8 months PSA value strongly predicts recurrence, progression-free survival and overall survival in PIECE-1. So patients with an unfavorable PSA decline probably require closer follow-up and monitoring. So these are the things the take-home messages from the STAMPEDE trial and the PIECE-1 trial. Next slide, please. So this is the treatment. These are the metastatic hormone-sensitive treatment options in 2022. So if it's a fit synchronous metastatic synchronous M1 patient, either a high volume disease and or a high risk patient. So in those patients, the options which are open is ADT plus abiraterone, ADT plus enzalutamide, or an ADT plus apalutamide, or a triplet in the form of ADT plus docetaxel plus abiraterone or a darolutamide. These are the 4 scenarios which is preferred for this group of patients. Next is the fit with synchronous M1 disease with a low volume disease and or a low risk disease. In these patients, what we prefer is that we use preferably abiraterone or an enzalutamide or an apalutamide along with ADT. If it's a fit with metachronous M1 patient with high volume disease and or a high risk patients also, or if it's a fit with metachronous and a low volume or a low risk patient, we prefer to use abiraterone with ADT or an enzalutamide with ADT or an apalutamide with ADT. Next slide, please. So next slide, please. So this is the PROPEL global randomized double-blind phase 3 trial in which one arm was randomized to abiraterone 1000 plus and olaparib in one arm, and another arm was abiraterone plus a placebo. The patient population was first-line metastatic CRPC, docetaxel allowed at the metastatic hormone-sensitive stage, no prior abiraterone used, other NHs allowed if stopped more than 12 months prior to enrollment, and if the ECOG performance status was 0 to 1. The stratification factors was either a bone-only disease or a visceral or other mets, and prior taxane at metastatic base was also, it was stratified into those two also. The primary endpoint was progression-free survival by investigator assessment, and the secondary endpoint was overall survival and other PFS2, overall response rate. So these are the secondary endpoints. Next slide, please. So in the BRCA mutant subgroup and the non-BRCA mutant subgroup, what we saw that 10.6% of the population of the trial population was in the BRCA mutant subgroup, and in this the median recurrence-free survival was not reached in the abiraterone plus olaparib, whereas it was 8.4 months in the abiraterone alone. In the non-BRCA mutated group, which comprised 87% of the trial population, so abiraterone plus olaparib, the median RPFS, recurrent PFS was 24.1 months, whereas it was 19 months in the abiraterone arm, which was with a hazard ratio of 0.76. So next slide, please. So if we see the subgroup analysis, what we saw that if it's a HRR mutation status, if it's an HRR mutant, or if it's a non-HRR mutated status, both benefited the abiraterone plus olaparib arm. It was benefited both of the patient, and BRCA and non-BRCA. It also benefited both the groups, although the benefit was seen more in the BRCA mutated arm. Next slide, please. So overall survival in the intention to treat population in this group also, what we saw that in the BRCA mutated one, median overall survival was not reached in both the arms, whereas in as per the updated results, and of course in this non-mutated also, it was not reached in both the arms. Next slide, please. So this was also a voting question which was done in the conference, during the conference. In the majority of the patients with metastatic CRPC that we are about to start an androgen receptor pathway inhibitor, do you recommend the combination of a PARP inhibitor as a first line therapy? So with a pathogenic BRCA mutation, with a pathogenic DNA mutation or non-BRCA mutation, and without a known DNA repair genetic alteration. So without a if it was a pathogenic BRCA1 or 2 mutation, around 50%, 48% of the population voted yes to use use a PARP inhibitor in the first line therapy. And if it is a pathogenic DNA repair alteration, not a BRCA1, still most of the doctors did not support this, and 78% voted against the use of olaparib. And if without a DNA gene alteration, we saw that 87 or 97% of the votes were against the use of a olaparib based treatment. Next slide, please. So this is the Keeling study, which is a phase 3 randomized open label study of pembrolizumab plus olaparib versus NHA for participation with previously treated metastatic CRPC. The eligibility criteria, it was a 2-arm study in which 200 milligram every 3 weekly and plus olaparib, and in the opposite arm it was abiraterone or an enzalutamide in the opposite arm. The dual primary endpoints was the free survival and the overall survival, and the other endpoints were overall response rate, safety, drug parameters. These were the other parameters. Next slide, please. So the primary endpoint in this pembrolizumab plus olaparib arm and the NHA arm. So what happened is that if the HRR gene mutation status was, if it was mutated, and if it was non-HRR mutated status. So in the mutated arm, what we see in the forest plot is that in mutated arm it favored the pembrolizumab plus olaparib arm, whereas in the BRCA mutated population also, if it was a mutated population, it favored the pembrolizumab plus olaparib arm. Next slide, please. So if you see the overall survival also in the BRCA mutated population, it favored the pembrolizumab plus olaparib arm, whereas in the non-BRCA mutated population, it did not favor the use of pembrolizumab plus olaparib. Next slide, please. So the take-home message from the PROPEL and the Keeling 012 trial was the biomarker analysis confirms the significant improvement of progression-free survival, mainly the BRCA mutated subgroup, 10.6% of the patients comprising in that, versus the intention to treat population of 100% patients. So overall survival data was not mature yet. So more treatment interruptions and discontinuations and more toxicity in the olaparib plus abiraterone arm, but no new safety signals with longer follow-up was seen. And in the Keeling 010 trial, olaparib plus pembrolizumab did not show relevant anti-tumor activity in the unselected patients with metastatic in the third line setting, even when compared to abiraterone and enzalutamide. Relevant activity in the PFS only in the HRR mutated subgroup was, and in the particular in the BRCA mutated subgroup was seen. OS only significant in BRCA mutated subgroup and the HRR mutated subgroup versus the non-HRR one. Next slide, please. So with this, I end my talk regarding the updates in prostate malignancy, which was presented in this year's ESMO.
Thank you very much, Dr. Tanmay Mandal. Right now, we do not have any questions. In case we have questions, we will come back to you. And now, Nero, can you share the introduction slide? Now I invite Dr. M.B. Chandrakant. He is DM Medical Oncology and DNB Medical Oncology. Is consultant medical oncologist at Narayana Health Super Specialty Hospital, Kolkata, young, dynamic, energetic. Over to you, Dr. Chandrakant, sir.
Thanks, Rajesh, for that kind introduction. And I would thank Ashok sir for this opportunity to speak on this platform. So this is an era where there are only speakers and there are no listeners. So, but we have so many listeners. I'm very fortunate to be over here. Let me just.
Sir, our listeners, this is on the faculty portal. Our listeners are on the
I know.
portals. Yeah.
No. I'm just saying that I'm fortunate, So sir mentioned that there are so many listeners, and I've heard about this masterclass quite, so thanks for, having so many people who can listen to me. So
you can make it full screen.
How do I make it? This is a PDF, no?
You can make it. Just drag this left side on right side of your screen. There is a arrow bar.
Yes. That's it.
Yeah. Further, Niro, can you help quickly? Or you open it?
Should I open it, Chandrakant sir?
No, this is okay, no?
Just put
no,
it.
This is not still full screen.
Not a full screen, sir. Just stop share and reshare it again, sir. Just open the PDF again.
Okay.
And once you open on your laptop, now there is a square column will come on the right top. Okay, click on that. It will come on the full screen of presentation.
Yeah, it depends on which app you open the PDF, I think.
Niro, you share it so that
I'll share it, sir.
Yeah. Chalo, okay, you only share. So, okay, so this is perfect, Okay. So, well, welcome everyone. Thanks all of you for joining, So in Kolkata, it's a puja time and it's a festive mood for all of us, So in this time, talking of academics is sort of a sin over here. But still, let me go through what are the recent advances. Before I presented this, I had heard here and there, but I had not known the data. But, in the last couple of days, I have gone through what is the data and I am also able to learn what is happening, how fast things are progressing. And if I'm not reading for a month, I'm totally out of box. So everything is new. So I will speak. Dr. Tanmay has well spoken about prostate. What are the new advances? I will speak on GU tumors, non-prostate, that includes kidney and urinary bladder. Okay, next. Yeah, this is this declaration. Okay, so these are the slides well made by the authors who presented, I think, wonderful slides, everything is so well put. So this is these are the RCC trials. And you can see ESMO 2022 has 5 trials which are very important. And you can see in none of the years you had so many trials being presented. So I can say you RCC, has really hit a peak where there is so much of development adding to survival in this particular subset. So I will be presenting those 5 trials. So the Cosmic 313 Pivot 09, no need of remembering the names, just to say that 5 important trials are there. And then I will say you about the urothelial carcinoma in the second part. Okay, next slide. So, well, we all know the way to treat kidney cancer localized is operated. So after doing surgery, you can see nearly 1/3 to half of them relapse. And the moment they relapse, we know what is the survival. So can we do something adjuvant, So sunitinib was there, which had some marginal adjuvant benefit. So do we have anything new? Do we have evidence for immunotherapy in this particular setting is what we will say. So adjuvant treatment for intermediate high risk clear cell RCC. Remember here, intermediate high risk in an adjuvant setting is different from a metastatic setting. In metastatic setting, it is an IMDC risk group, whereas in adjuvant setting, it is a PT2 with a high grade, grade 3, grade 4, or a PT3 disease, or if there is a sarcomatoid component in it, or if there is node positivity. So just to remember, T2 with high grade, any T3 and above, any node positive. And one important subset is M1NED. M1NED means we know that kidney cancer is an oligometastatic disease. Even if we have benefit of operating it. For example, we had a renal mass and one single lung mets. So we can operate them. So that is called as M1NED. That is, you have metastatic disease. After that, there is no evidence of disease in the post-operative scan. So this is what is the definition of intermediate high risk in the adjuvant setting. You can see nearly half of them relapse if they are really high risk. Therefore, you need to do something in the adjuvant setting to improve the cure rate. Okay, next slide. So these are the important trials in the adjuvant setting. You can see they have used sunitinib, pazopanib, axitinib, sorafenib, everolimus. All the drugs have been tried. It is very important to remember negative trials, because we know these drugs are not going to work. Positive trials, anyways, we will come to know, but negative trials will help us in selecting, which agents at some point of time. So negative trials are sort of more important than positive trials. So among all these adjuvant TKI trials, S-TRACK trial, sunitinib versus placebo for 1 year, which had fairly good number of patients, had a disease-free survival benefit, and this has been approved right now, but this is not yet practice changing, because the magnitude of benefit what we have is not that great. There's a toxicity of treatment is too much, discontinuation is too much, therefore, and the overall survival data is not there. Therefore, sunitinib, even though there is a good disease-free survival benefit, because of these shortcomings of not significant disease-free survival benefit, toxicity, and not converting to overall survival, plus no other trial replicating it, this is not yet a standard of care. Next slide. So this is the 3 randomized controlled trials which failed. I was looking into what is LBA. I googled, I found it low backache. Then I saw it is late breaking abstract in ESMO. So these are the late breaking abstracts that was presented. IM motion 010 was atezolizumab. It is a negative trial. So in adjuvant setting, atezolizumab does not work. Checkmate 914 is nivolumab plus ipilimumab. Again, this does not work in adjuvant setting. And Prosper is peri-operative nivolumab. Like I gave nivolumab and then I did surgery and then I gave more nivolumab. This is also negative. So we have 3 important drugs, 3 important combinations: nivo, ipi, nivo, and atezo. All these 3 does not work in the adjuvant setting. Next slide. So these are the trials. So nivo, ipi doesn't work. Atezolizumab doesn't work. Peri-operative nivolumab doesn't work. And durva tremelimumab, that's also a PDL1 blocker and a CTLA4. Its results are awaited. So the only winner as far as adjuvant RCC is concerned is pembrolizumab. Keynote 564 is the number, and you can see pembrolizumab versus placebo. Nearly 1,000 patients were recruited. Hazard ratio is impressive, 0.68, and it was well tolerated. Therefore, based on this, pembrolizumab is approved in the adjuvant treatment of RCC, intermediate and high risk. Intermediate and high risk means PT2 high grade or T3, or if there is sarcomatoid component or node positive or M1NED. So these are the subset of patients in whom we can offer pembrolizumab in the adjuvant setting. However, this is the next slide. Okay, so why did they fail? There are multiple reasons. Selection criteria is different, endpoints are different. I will tell you what are the probable failures of trial. Okay, next slide. So this is the thing, nivo-ipi failed, and you can see the number of patients who required discontinuation. Nearly 30% patients led to treatment discontinuation because of treatment related adverse event in Nivo-EP. Therefore, they couldn't give properly, and therefore in adjuvant setting, the threshold for toxicity is sort of too much. It's a patient who has no symptoms, and the acceptance of toxicity is not that much. So that's a challenge. Okay, next slide. So what does this slide say? So with this, we can probably say in RCC, you have atezolizumab, bevacizumab combination. We have atezo mono. None of them have shown excellent responses, excellent progression-free survival or overall survival. Probably in the RCC subset, maybe PD-1 is better. And we also have avelumab axitinib combination has a benefit. I'm not saying no, but not to the extent of PD-1 blockers. So probably, there is some hypothesis generating that PD-1 is the way to go and not PD-L1 in RCC, and especially I would say not in the metastatic setting, but in the adjuvant setting. Pembrolizumab is the only winner we have right now, and you can see the diamond, really good. To have a benefit in the adjuvant setting, the drug has to be really effective. And you just see the hazard ratio for sarcomatoid 0.54, hazard ratio for M1NED 0.28. I think these are practice changing. So tomorrow morning, if a patient comes to me with a sarcomatoid or with an M1NED, oligomets operated, rather than observing, the chances of he relapsing is 50%. I would definitely offer him pembrolizumab if there is logistics, because looking into the hazard ratio of this particular subset. Okay, so PD-1 is the way to go. Pembrolizumab is a clear winner as of now. Overall survival we don't have right now, but the primary endpoint has been met. Next slide. So this is the PROSPER study, that is a peri-operative Nivo. They gave 1 Nivo before surgery and 9 doses of Nivo. But this is challenging in kidney cancer. This is because not everybody will respond to Nivo, because if I use Nivo mono, you have 40% patients progressing on this. So the responses are not there, number one. So everybody may not get converted to surgery. Plus, after you have a surgery, to start next nivolumab may be delayed because of post-operative complications. Therefore, peri-operative immunotherapy did not succeed because of these multiple explanations, because the patient would have progressed on Nivo, or to start nivolumab subsequently would have been delayed. Okay, next slide. So these are the possible explanations for why peri-operative Nivo failed. Open label study, and there was no independent review committee involved. Imbalance and delays, toxicity and response. Not all had surgery, and delay in starting adjuvant immunotherapy. So adjuvant nivolumab. So these are the probable reasons. So nivolumab was not a winner in the peri-operative setting. Next slide. This is the data which I think before I finish the talk today, this is the slide that all of you have to remember. The hazard ratio is 0.52 for the updated DFS. For updated DFS and the overall survival, the hazard ratio is good. You can see it is impressive. The median is not there, but at 24 months, at 30 months, impressive hazard ratios, 0.52, 0.63. I think you guys remember the previous slide of M1NED, where the hazard ratio was somewhere around 0.2. So impressive. So this is a slide that you need to remember, and we must offer pembrolizumab in affording patients. Next slide. So adjuvant pembrolizumab should be considered optional for patients with intermediate high risk operable clear cell RCC. So remember every word, it is clear cell RCC. After careful patient counseling regarding the immature overall survival and the potential long-term side effects of immunotherapy. So further data are required in the future, including the positive OS data. However, if you look into the hazard ratio, looks impressive. With this data, I would suggest to sort of give an option of adjuvant pembrolizumab for intermediate high risk operated clear cell RCC in the present day. Next slide. So well, there are so many options in metastatic RCC. Every drug, every combination is approved, and to add to it, there are triplets right now. So if you look into the ESMO recommendations for favorable risk, we have IOTKI. First came the Pemroaxi, then came Pemrolenva, then came Nivo-Cabo. Of course, Avelumab Axitinib is also there, but is not there in the ESMO recommendation. And then coming on to intermediate and poor risk IMDC. So here the intermediate poor risk is different, IMDC is different, and in adjuvant it is different. So here you have in addition Nivo-EP right sitting over there. So, and we have IOTKI. So there was always a issue with the IO-IO combination. The problem was that 30% patients had disease progression as a best response in the first 3 months. So because of this IO-IO, if there is heavy disease burden where I cannot afford progression, I was not comfortable offering IO-IO in these patients. So to overcome that, there is a trial, the COSMIC trial, where there is a triplet combination. Next slide. So this is important. This is another take-home slide for all of you today, the COSMIC trial. So you can see RCC is a disease where we have divided into 3 groups: good risk, intermediate risk, and poor risk. Intermediate risk is the big chunk that is there. Good risk is more VEGF mediated. It is sort of lower grade disease and not fastly multiplying. Their TKAs work well. Therefore, sunitinib monotherapy is a reasonable option in the good risk, or pazopanib monotherapy is a good option. Therefore, IO-IO has not done well in the good risk group because VEGF is the driver in a good risk patient. In a poor risk, it is more IO mediated. Therefore, there I want IO to be there. Intermediate risk has both components. It has both VEGF and also IO. So therefore, this becomes important. So to overcome this, the COSMIC trial did triplet. You can see it is triplet versus doublet. We initially had Nivo mono in the second line, and then we had IO-TKI and then IO-IO, and now we have the triplet over here. So it is 1:1 randomization of intermediate and poor risk patients. It is Nivo, EP, Cabo, followed by Nivo Cabo maintenance versus Nivo EP, followed by Nivo maintenance. So these are the comparator arms, and the primary endpoint was PFS, secondary endpoint was survival and response rates. Next slide. So the responses are better, Nivo, EP, Cabo. So that initial worry of 30% patients progressing as the best response is taken care. If I can add cabozantinib to Nivo EP, so definitely there is an improvement in the response rates. And you can see the number of patients progressing have reduced, 55 versus 23. I am able to take care of that percent of patients where disease progression is the best response with this triplet. Next slide. So this is the ITT population. The progression-free interval is significant. Hazard ratio 0.73. Positive trial triplet. There is a promise. You're taking care of the initial progression, the progression-free survival, and the response rates are better. Next slide. So this is important. 42% did not receive 4 doses of EP. Difficult to handle, that's what they're saying. 45% patients had treatment-related adverse events resulting in discontinuation. So when I use IO Cabo triplet, we all know Cabo is not that easy to handle, and we all know EP can be, with 1 milligram per kg, it should be fine, but still, EP Nivo has a bit of IRAE. So yes, triplet can be given if you are concerned about disease progression, but be ready for the toxicity, significant discontinuation, and not everybody in a clinical trial. 42% did not receive 4 doses of EP. You need to be careful about this. Okay, next slide. So these are all the slides what we have right now. The control arm being sunitinib with all of them. So But the only positive thing about the cosmic trial is the comparator arm is Nivo-EP. There was no trial where the comparator arm was immunotherapy. Cosmic trial is the first trial where the comparator arm is IO. So this is a unique trial when compared to all of them. So otherwise, all the comparator arm is sunitinib monotherapy. Next slide. So this is how we are changing. We are seeing a change in the comparator arm. So we had everolimus as a comparator arm in the second line when sunitinib, when we had nivolumab mono, the comparator arm was everolimus. And now you see the comparator arm. Comparator arm is Nivo-EP. You are having IO coming up in the comparator arm, and if you have IO, and now we have IO TKI being the standard arm. So this is the first results of a phase 3 clinical trial using a contemporary control arm. That's really good. First results of a phase 3 clinical trial comparing triplet to doublet. First results of a phase 3 clinical trial meeting its primary endpoint of PFS. So this is another important thing that we can remember today. Cosmic 313 first trial to have IO as the control arm. IO as the comparator arm. Okay, next slide. So overall survival, toxicity. This is we can discuss, which patients we can put, which patients we can avoid, but this is what evidence we have right now. Next slide. Well, this is important. I was really impressed with this novel drug, specifically addressing a good risk subset. So good risk is where I'm not sure how much IO does. I'm really more concerned about the VEGF pathway, because we have sunitinib mono has shown excellent progression-free survival in the first line. In fact, Nivo-EP failed to show response in the first line. So I personally feel RCC is a spectrum, VEGF mediated to IO mediated. So the moment it is good risk, I am more concerned about VEGF pathway. I want to inhibit the VEGF. To answer this, we have a new drug right now. If you look into the pathogenesis of RCC, the first page of data, nowadays we don't read, but there is a nice page explanation with a nice diagram saying how HIF mediates the pathogenesis of RCC. Definitely in a good risk subset, RCC, definitely VEGF therapy works. So we should remember that interferon bevacizumab was standard of care, and bevacizumab had a definite role in this subset. Next slide. So if you are using anti-VEGF like bevacizumab, there is a HIF2 activation. Therefore, it makes sense if I inhibit the VEGFR and also the HIF2. And to answer that, this is the new drug. It is belzutifan. So I think it will take some time to learn the name. But this is what we have. This locally advanced metastatic RCC. Either treatment naive or has received prior immunotherapy. 2 regimens is the maximum number. And this was randomized. This is not randomizing. This is cohort 1, where they used cabozantinib belzutifan, which is a HIF2 inhibitor, and the cohort 2 was prior immunotherapy, and the primary endpoint was response rate. Next slide. So I would like you to remember one thing in this. Just focus on the response rates in the favorable subset. 62% response rates. Important. So the moment I combine a VEGF blocker like in this, it is Cabo with a HIF2 in a good risk setting, you can see the responses, 62% responses, which is impressive. And you can see 10% CR in the favorable subset. We don't expect that because this is not a high-grade disease. This is a slow-going disease. In that, if you are having this much amount of responses, probably we are hitting hard on the VEGF pathway. So therefore, remember this new drug, especially in the good risk subset, it is more VEGF driven. Keep an eye on this. Let's see how it does in future. But the moment it is favorable risk, TKI, excellent. TKI with, the moment I give TKI, I am just inhibiting the VEGF pathway. And to overcome that, there is HIF2 coming up. So to have a complete blockade, I can have a VEGF TKI and a HIF2 inhibitor. So this is another one which you can remember, 94% reduction. This is really phenomenal. Again, good risk. Remember this regimen. Next slide. So this is another important one for non-clear cell. We had no data for non-clear cell. We were struggling. And here we have pembrolizumab right now coming up. So this is the data we had: cabozantinib, sunitinib, pembrolizumab, and we had savolitinib in MET-altered tumors. Next slide. So this is pembrolizumab plus lenvatinib. We know this is one of the wonderful combinations, and just focus on the dose of pembrolizumab. 400 milligram once in 6 weeks. So the doses of IO can be altered, just like trastuzumab, 8 per kg, 6 per kg, 4 per kg. Even this can also be 200, 400, depending on the duration of administration. And this did include non-clear cell RCC, locally advanced metastatic, no pre-systemic therapy, measurable disease, good KPS. Primary endpoint, response rates as per RESIST. Next slide. So looks promising. Pembro-lenva in this subset of non-clear cell RCC, 47.6%, and this is control rate of nearly 80%. Looks impressive. This is sort of a difficult subset. Clear cell is more sensitive to treatment. Non-clear cell is resistant. We don't see, we still remember TEM sirolimus coming there and sitting in some point. But right now we have this pembrolizumab plus lenvatinib showing promising responses. I think this is one of the most potent combination that we have. So impressive. Remember this regimen for a non-clear cell patient for tomorrow. Next slide. Look at the responses for papillary histology. Excellent responses with pembrolizumab. And look at the numbers, 86%, 80%, 93% with translocation. Remember, translocation associated RCC is very important. Translocation associated RCC is something like a young lady or in a younger age subset coming with extensive disease. Bone marrow mets, you don't know, it's a carcinoma unknown primary, and then you do a bone marrow and you find out clear cell RCC, or RCC being there. So this is how translocation is with RCC, and they're exquisitely immunosensitive. And you can see the responses, 93% responses. Therefore, whenever you see a young patient coming to with RCC, just brighten your eyes and see, am I dealing with translocation associated and IO sensitive disease? 93% responses. Next slide. So first line treatment of non-clear cell RCC. Here we have Keynote B61 pembrolizumab shows promising response rate signal for non-clear cell RCC, including papillary and off-note also chromophobe histology, in addition to cabo, sunitinib, pembro, and savolitinib in MET-altered tumors. So this is another take-home, pembrolizumab in non-clear cell RCC. Next slide. Okay, so I think we had reasonably good take-home messages from RCC. Let's quickly go through urothelial cancer. I have only one important trial which I can address. Next slide. So this is the way we treat RCC, treat a urothelial cancer metastatic. If a patient is cisplatin eligible, I will give cisplatin-based chemotherapy, Gemcis or Dosansamvac, and I'll put on avelumab maintenance. If not, Gemcarbo and then avelumab maintenance. And then in subsequent lines, we have these drugs, enfortumab vedotin, promising, erdafitinib in FGFR, and we also have sacituzumab, which is not there here. And then coming on to the subset where they are ineligible for even carboplatin, in that subset, if the PD-L1 is positive, we have evidence for both Atezo and Pembro. And then once they progress, again, you can consider enfortumab vedotin in this subset. So if any platinum eligible, always give platinum in the front line and then go ahead with avelumab maintenance and then reserve the drugs for third line. Whereas if not eligible for chemo at all, and then you can give Pembro mono, Atezo mono, and then at progression, you can consider this. Okay, next slide. So I would draw your attention on the response rates of Gemcarbo. Not that great, and the durability is less with Gemcarbo in platinum. When you look into the right last column, enfortumab plus Pembro, chemo-free regimen, and we are speaking of high-grade urothelial cancers, platinum ineligible. Look at the response rates, look at the duration of response, look at the disease control, 93%. So Pembro plus enfortumab, metastatic, unfit for platinum, I think this is really surprising. This is a subset where the patient is going to die very soon. Even in that subset, the durability is excellent, disease control rate is excellent, response rate is excellent. So this regimen is going to be there with us in coming future. So chemo, the response rates are there, but it is not durable. If you have enfortumab in combination with pembro, look at the response rates, look at the durability, look at the disease control rate. Impressive. Next slide. So this is the trial which I was saying. Enfortumab in combination with pembrolizumab, impressive results. Primary endpoint as response rate in cisplatin ineligible patients, first line. Next slide. So this is the response rate. The overall response rate were consistent across the pre-specified subgroups. 53.8% confirmed overall response rate, even in patient with liver mets. Activity is consistent with experience in second line enfortumab monotherapy. So this regimen is good. Pembro in combination with enfortumab vedotin, promising responses. So this drug is going to come up, enfortumab vedotin. Next slide. Look at the responses. Activity occurred regardless of PD-L1 status. Next slide. So the problem with enfortumab is peripheral neuropathy. You must remember, peripheral neuropathy is something like brentuximab vedotin. I think we have heard. So similarly, enfortumab vedotin, peripheral neuropathy is an issue which we must remember. Otherwise, pneumonitis, respiratory failure, sepsis, rare side effects are anyways there. Next slide. So this is how we can think of treating urothelial cancer in the present day. PD-L1 is a biomarker, most robust data, but needs the sensitivity, specificity are not foolproof. You could see that irrespective of PD-L1, there was a response. TMB, somatic alterations, molecular subtypes, gene expression. So these are some things, biomarkers which can be thought of in future. Next slide. So well, before I conclude today, so few take-home messages for RCC. We can, very important to remember negative trials. None of the PD-L1 inhibitors, atezolizumab, has shown negative trial, and then nivolumab, perioperative, negative, nivo-EP, negative, pembrolizumab in intermediate and high risk adjuvant setting has shown an impressive disease-free survival. Remember the subgroup of M1NED. This is one. Number two, remember, okay, next slide. Yeah, so number two, remember non-clear cell RCC, pembrolizumab with lenvatinib did really well, impressive responses. And number three, you must remember the HIF2 inhibitor in combination with cabozantinib, extremely good in the good risk subset, which is more VEGF driven. And then coming on to the urothelial cancers, platinum ineligible, enfortumab vedotin in combination with pembrolizumab, excellent responses and durable responses in this difficult to treat subset. So with this, I would thank all of you for patient listening, and back to you, sir. You're muted, Rajesh.
Thank you very much, Dr. Chandrakant. It was a power-packed presentation. In fact, I would say it is 5 presentations in one presentation. iMotion, Prosper, Checkmate, Pivot, Cosmic, and you simplified all that in quick 25 minutes. Thank you so much. Now I invite, before I invite Dr. Saurabh Mishra, last presentation was 5 in 1. So this is only one single. Why this is one single trial is so important. It was initiated in 2005, and over last 17 years, more than 10,000 patients have joined in this trial, STEMPED, acronym for which is systemic therapy in advancing or metastatic prostate cancer, evaluation of drug efficacy. And it has evaluated multiple things. With this, I would like to invite Dr. Saurabh Mishra He is Associate Professor, Department of Medical Oncology at AIIMS Bhubaneswar. He is DM Medical Oncology from Cancer Institute, Adyar. And over to you, Dr. Mishra.
Thank you, Rajesh. So can I share my screen?
Yes.
Yeah. So please let me know if you can see my screen. Can you see my screen?
Yes.
Yeah. So now are my slides visible?
Yes. You have to make it full screen. Yes.
Yeah. Yeah.
Very much.
So thank you there. Thanks a lot, Dr. Professor Vaid, and for having me here. And we have listened to the last two speakers who have really summarized the outcomes of the data which was presented at ESMO 2022. And in fact, most of these data have been useful in our clinical practice. Prostate cancer is one of the biggest problems in our clinics as well, as our population is aging. Accordingly, we see more and more number of prostate cancers. In fact, the Indian patients of prostate cancer are much more having an advanced stage of disease. That's what we have seen in our clinical practice. So that is why there has been always an interest to combine androgen deprivation therapy, which is the backbone of treatment of prostate cancer, with additional therapy. So we have previously had data from combination of docetaxel with androgen deprivation therapy. And so first line is now flooded with a cornucopia of options, plethora of options. And therefore still there is a requirement, there is an understanding to add more. And therefore this is the Stampede study platform protocol, in which there were multiple subset of patients, both metastatic and non-metastatic, who were taken up for variety of treatments. And this is an analysis which was the first combined analysis of metastatic patients who were started on androgen deprivation therapy, and they were either randomized to abiraterone acetate and prednisolone alone, or another trial was the enzalutamide and abiraterone with prednisolone. So both of these were phase 3 protocols from Stampede, and this was a comparison of this. So if you come to the background, as I said, both in their own capacity, abiraterone with prednisolone or enzalutamide, when combined with androgen deprivation therapy, have improved outcomes from metastatic hormone-sensitive prostate cancer. So both of them have led to improvement in overall survivals. For the abiraterone prednisolone, we had the Latitude trial, the Stampede trial. For enzalutamide, we had the Enzamet study. All of these had led to improvement in overall survival in metastatic hormone-sensitive prostate cancer. We know that abiraterone is a steroid pathway synthesis inhibitor, and we know that enzalutamide is an androgen receptor blocker. So there is a rationale for combining androgen receptor blocker with the androgen pathway synthesis inhibitor, because as you block the androgen pathway synthesis inhibitor, there is reflex overactivity of the androgen on the androgen receptors. So there is a rationale for feedback. There is increase in feedback androgens and activity on the androgen receptor, and therefore the combination of an androgen receptor blocker and a androgen pathway synthesis inhibitor does make sense. However, if you see the combination strategy of enzalutamide and the abiraterone prednisolone, in the previously data which is been there in metastatic castrate-resistant prostate cancer, there have been 2 randomized studies, but none of them have led to an improvement in overall survival. They have not led to, combination has not led to an improvement in overall survival, although there has been an improvement with radiologic progression-free survival with this combination. And of course, as of now, there is no clarity of data of this combination in metastatic hormone-sensitive prostate cancer. So this study tried to ascertain that. Secondly, it also tried to understand the long-term impact or long-term outcome on overall survival of androgen deprivation therapy, along with a second-generation hormonal agent that is more than 5 years have been not been previously reported. So now that data was also to be seen. That is the abiraterone long-term data. So if you come to the Stampede protocol, as Rajesh was saying, so that included patients who had both metastatic hormone-sensitive prostate cancer, as well as there were patients who were non-metastatic but high risk of recurrence of prostate cancer. So these were the adjuvant setting, and these included patients with like node positive subset, or if they were node negative, they should have more than equal to 2 high risk features, and that included the Gleason score and the T3, T4 status. All of these were also high risk of recurrence. So both the sort of patients were included in this Stampede protocol. All of them had a confirmed diagnosis of prostatic adenocarcinoma, and they were all excluded if there's clinically significant cardiovascular disease, because as we know, androgen deprivation therapy does predispose patients to cardiovascular worse outcomes. So in this Stampede platform protocol, we have previously had data on the indirect comparison of abiraterone with versus abiraterone plus enzalutamide in the non-metastatic prostate cancer setting. And this has been published in the Lancet. And in this indirect comparison, it was seen that among men with high-risk non-metastatic prostate cancer, combination therapy with abiraterone and enzalutamide is associated with significant, significantly higher rates of metastasis-free survival compared with the androgen deprivation therapy alone. So this was a meta-analysis of abiraterone acetate and prednisolone with or without enzalutamide. And abiraterone acetate with prednisolone should be considered as a new standard. So there were 2 arms again which were combined in this study. So in this study, the abiraterone arm, they did find to have an improvement in outcome, only the abiraterone arm. However, when you combine the abiraterone with the enzalutamide, there was no difference in the metastasis-free survival when enzalutamide and abiraterone acetate were administered concurrently compared with abiraterone acetate alone. So in this high-risk subset also, if you combine abiraterone with enzalutamide, you did not get any improvement in overall outcomes compared with the abiraterone alone. That is mainly the metastasis-free survival. So this is the background which was already there. In this background, now we come to the current study. So which was done that the randomized groups, that was one study was the enzalutamide with abiraterone in metastatic hormone receptor prostate cancer sensitive, and another was the only abiraterone along with androgen deprivation therapy in the same metastatic hormone sensitive prostate cancer. The median age was 68 years. The median PSA prior to androgen deprivation therapy was 96 nanogram per ml. Majority 94% with de novo metastatic disease. And the median follow-up in the abiraterone only trial was 95.8 months. So we have more than now nearly 8 years of data for this trial. And for the abiraterone and enzalutamide combination study, we had approximately 72 months of follow-up was already there. So at trial closer in the app trial, there were already 23% of the patient, 1/4 of the patient were still on the abiraterone arm. And in the abiraterone and enzalutamide trial, almost same 25% of the patients were still there. So now coming to the indirect comparison. So as I said, this was an indirect comparison. There is no head-to-head comparison here. But even in this indirect comparison, we see here that although in their own capacity, the abiraterone, it led to an improvement in overall survival compared to standard of care. So the hazards ratio was 0.68 and the p-value was very significant, very significant. And here again, in the combination of abiraterone with enzalutamide, the hazard ratio was very similar, 0.65. So in their own capacity, either as abiraterone or abiraterone with enzalutamide, when compared to standard of care, would lead to an improvement in overall survival. But when we go for the interaction hazards ratio, that is, we compare the interaction in hazards ratio, the test of interaction between these 2 studies, that is an indirect comparison of the outcome. And we see here that the hazards ratio is 1.05 and the p-value is not significant. If this would have been significant, we would have thought that there is some difference in the outcomes between these trials. And also, if we go for between trial heterogeneity, so heterogeneity means that if there was significantly different significantly different trial design, we would find a heterogeneity in the study, and this would creep into the results. But here we see that the between trial heterogeneity was not there. That means the trials were not very heterogeneous. They were similar sort of population, and therefore the P is 0.7. So with this background that these trials were not very heterogeneous, and with this background that abiraterone itself improves outcome and the abiraterone with enzalutamide itself increases outcome, there was no statistically significant difference in the overall survival between abiraterone alone and abiraterone plus enzalutamide. So this also reflects in the subgroup analysis. So the minimization factors, including, we can see here that there was again not much of a difference when subgroup analysis were done between the abiraterone only and the abiraterone with enzalutamide. Also included were the subgroup with the docetaxel plain patients, and they were again not very significant differences. When we come to the metastatic progression-free survival, we see here that between the abiraterone trial and between the abiraterone and enzalutamide, again, there was a significant difference on their own capacity between the standard of care and these drugs. But there was no evidence of a difference in treatment effect or between trial heterogeneity. Again, very similar result. So there was no difference in the outcomes when abiraterone was compared with abiraterone plus enzalutamide, similar to the overall survival outcomes. But one thing is very clear: if you combine two drugs which have different sort of toxicities, as we know, the abiraterone plus prednisolone, especially abiraterone, leads to mineralocorticoid excess, and therefore we combine prednisolone along with that to prevent this mineralocorticoid excess and their toxicity. And enzalutamide has seizures as a side effect. And when you combine this enzalutamide with abiraterone, you would find, and you would expect, and you would find also more number of toxicities. As you can see on the right graph, the number of patients with all sorts of toxicities that would automatically be higher. So we are getting more toxicity with this combination. We are not getting benefit with this combination compared to abiraterone alone, neither in terms of overall survival, neither in terms of the radiologic progression-free survival. The second point, which was the primary outcome or analysis of this study, was that what was the survival outcome with abiraterone at 7 years, at a prolonged follow-up? What was the survival outcome? So did the survivals persist, or did they plateau, or did the survival difference fall? So here we can very well see on the left side, you can see that at 84 years also, the absolute difference in overall survival from beginning to 0 months, 6 months, 12 months, steadily it has improved, and now it has almost become plateaued. So that is the overall, the absolute difference in event-free survival between abiraterone and the standard of care, it has kept on improving. Similarly, the hazards ratio has been very static over a period of time, somewhere hovering around 0.4 to between 0.4 to 0.6. It has not come down, showing the continuity of effect, showing the long-term effect of abiraterone, which is maintained over a long period of time. So the patients alive at 84 months with androgen deprivation therapy alone are 30%, and with androgen deprivation therapy and abiraterone and prednisolone 48%. So there has been a very significant improvement in the overall survival in these patients, and this has been maintained. So the conclusion from this study was that the enzalutamide with abiraterone prednisolone should not be combined for metastatic hormone-sensitive prostate cancer, neither for high-risk localized prostate cancer, as was also seen in the initial study from the Stampede protocol. This was because by indirect comparison, there is no additional benefit of combination of enzalutamide with abiraterone. And also the clinically important improvements in overall survival with abiraterone and prednisolone added to androgen deprivation therapy, they are maintained at 7 years. There are certain limitations. So as per the authors, this was an indirect comparison. So there is no head-to-head comparison, or there is no head-to-head trial which has compared abiraterone plus enzalutamide versus the abiraterone alone. And this is an indirect comparison. So indirect comparison of two trials, however, unlikely to have missed an effect of size of interest. Had there been genuinely a difference or outcome in the outcomes, it would not have been missed by this. And there was no comparison with androgen deprivation therapy with enzalutamide. So this would have been interesting to see how did abiraterone plus enzalutamide compared to enzalutamide alone. Here we compared abiraterone plus enzalutamide versus abiraterone, and we found that there was no significant benefit of a combination of abiraterone and enzalutamide. So there is no comparison with androgen deprivation therapy with enzalutamide. And further treatment combinations will require patient selection. So this is, as I said, there are plethora of options. So many options in metastatic hormone sensitive prostate cancer. One way of starting the treatment is to look at the volume of disease. High volume disease or high risk disease, we usually go for chemotherapy or doublet combination of chemotherapy with the newer hormonal agents. If it's a low volume disease, we usually go for androgen deprivation therapy along with only hormonal therapy. So my take is that, so as I said from the very outset, the science behind this combination of abiraterone and enzalutamide is solid. One of them blocks the steroid pathway, and the other is an androgen receptor blocker. So we would think that there is some synergistic effect. And also previously, we do not have any data to say that what is the sequencing for abiraterone and enzalutamide, whether if you earlier use enzalutamide and then abiraterone, whether outcomes are going to be better, or whether it is abiraterone followed by, enzalutamide followed by abiraterone. We do not know that. So with this science, which is very solid, we still see that this similar treatment works very similarly in very different settings. That means this combination of abiraterone and enzalutamide, it does not cause improvement in metastasis-free survival in the setting of non-metastatic castrate-resistant prostate cancer. Similarly, in metastatic hormone-sensitive prostate cancer also, the metastatic castrate-resistant prostate cancer setting. So metastatic hormone-sensitive prostate cancer, just now we presented. Also in the metastatic castrate-resistant prostate cancer, so there was another trial like that. So also there was no improvement in overall survival with the addition of enzalutamide to abiraterone. So this combination probably does not work in these very different settings, and although this is a similar combination. However, there is some combination which is working. There is the abiraterone acetate with apalutamide. There has been a data to show that with primary endpoint of radiologic progression-free survival, there was almost a 6 months difference when apalutamide was combined with abiraterone compared to abiraterone alone, although there was no significant improvement in the overall survival in the metastatic castrate-resistant prostate cancer. So probably not abiraterone plus enzalutamide, but abiraterone plus apalutamide may have some effect. But what has been shown to work as a combination strategy is a combination of chemotherapy and the newer hormonal agents. So as we know, the PEACE-1 study was very well presented here, and that docetaxel with abiraterone with prednisolone does lead to a significant improvement in overall survival. There is no doubt about that. So now for the very fit patients with high risk disease, as was the poll which suggested, we can try this combination of docetaxel with abiraterone and prednisolone. Similarly, if you go for the ARASEN study, we can see here the combination of docetaxel with subsequent generation androgen receptor antagonists like the blockers like darolutamide. So docetaxel with darolutamide has also led to an improvement in overall survival based on the ARASEN. So probably this combination is what actually works rather than abiraterone and prednisolone with enzalutamide. So with this, I would like to conclude my talk. I would like to again thank the masterclass organizers for giving me the opportunity to present this paper. And if there are any questions, I'll be happy to take them. Over to you, Rajesh.
Thank you very much, Dr. Mishra. Now there are 2 questions in the question box.
Okay.
Can I? Yeah. So question number 1, Dr. Gagandeep Singh has asked, if patient is not affording Pembro or not giving approval, department not giving approval, any role of simpler drugs or older drugs in adjuvant, so soranib or sunitinib or chemo?
So Chandrakant, you can take it. I mean, you presented the paper. If
So,
he is
well,
there.
yeah. So if you look, you have approval for adjuvant sunitinib, and it is a positive trial for DFS, but there is no overall survival benefit. Number one. Number two, toxicity. A lot of discontinuation. Nobody can comply to that 1 year of sunitinib. And number three, the magnitude of benefit is not that great. So because of these three reasons, even though there's an approval, because of marginal benefit, more toxicity, and not translating to overall survival, sunitinib, even though there is approval, we are not yet practicing it in the adjuvant setting. Saurav, you can add for it.
I would completely agree with you. So this is definitely a difficult option, toxic option. And when we do not have so much of overall survival data, it is genuinely difficult to say to the patients that why do you want to give this drug? So I would still go for observation as far as the data is concerned, if at all I'm not able to use immunotherapy.
Thank you, Doctor. Next, one more question is Dr. Raghavendra Rashikar has asked where to look for ongoing and just completed clinical trials. I think he's impressed with the latest presentations of so many clinical trials. Dr. Mishra, would you like to take this?
So I didn't get the question actually. So
where to look for ongoing and just completed
Okay.
clinical trials? Where do you want to get alerts, automatic alerts?
Okay. So I think we have this group in this medical oncologist forum. We do have these trials. So whenever we have such a patient, we do call our colleagues and we find out if they have a trial with them. So that is one way of looking, or you can look at the DCGI website if there are certain trials which are ongoing with any of the indications, as I said.
His question is just completed trials, so that not the upcoming trials. So probably the Medscape and ESCO JCO alerts will be the right.
Okay. I mean, the where to look about the data. Okay. I think you can find it in the up-to-date also. Sir, over to you.
If one subscribes to Medscape, I think every morning you have a list of whole new things, and then some good trivia also coming to you. You know, not only the trials, but some gossip and medical gossip and oncology gossip.
Correct. Agree, sir.
Keeps the whole matter very light.
Thank you, sir. Now, Nirav, now I would like to invite Dr. Jyoti Wadhwa. Dr. Jyoti Wadhwa is Director of Medical Oncology, Vedanta, the Medicity Hospital, Gurugram. Dr. Jyoti Madam has even more challenging tasks than Dr. Chandrakant. She has to summarize all this. Madam, over to you.
Yeah, thank you and good evening, everyone. The task is really tough because the presentations were content heavy, but the topics have been dealt really well in a very crisp manner. So I would try to sum up the presentations. So let me start with the presentation by Dr. Tanmay. He presented the data recently presented about genitourinary cancer, prostate cancer. And we know that the treatment landscape for prostate cancer continues to evolve. So we now are more clear that there is a role for adjuvant radiotherapy in patients after radical prostatectomy if they have high-risk disease based on the T stage, the nodal stage, the positive margin status, and also depending on whether there were 3 or more sites of positivity. Subsequently, he presented the data of piece 1, wherein ADT was combined with docetaxel and abiraterone in de novo metastatic castration-sensitive prostate cancer. And this triplet was found to improve overall survival and radiographic PFS with modest increase in toxicity. And the main toxicity was hypertension. So this triplet could in fact become a standard of care for these patients. Subsequently, he presented the PROPEL study. This did document significant improvement in radiographic PFS for olaparib with abiraterone, versus placebo with abiraterone in patients with newly detected T1, the treatment naive metastatic CRPC, irrespective of HRR status. However, we know that the results were superior in those who had BRCA mutation positivity. The last trial that he presented was the KeyLink 010, wherein the combination of olaparib with pembrolizumab did not show the relevant anti-tumor activity in unselected patients of metastatic CRPC in third-line setting. Let me continue prostate cancer data, which Dr. Saurav Mishra presented, wherein he presented the phase 3 Stampede trial, wherein abiraterone acetate was compared with the combination of abiraterone acetate with enzalutamide. So in this trial, there was long-lasting, clinically meaningful overall survival benefit in patients with metastatic hormone-sensitive prostate cancer with abiraterone with prednisolone in combination with ADT. So the efficacy of abiraterone is well documented. The benefit was continued over long-term follow-up. However, the combination with enzalutamide could not be recommended based on this trial for either metastatic hormone-sensitive prostate cancer or high-risk non-metastatic disease, since there was no improvement in the progression-free survival with this combination. And even though either of the arms were quite good when compared to the standard of care arm alone. In terms of safety, the toxicity was similar, though more frequent side effects were noted in the combination arm. Coming last to the presentations by Dr. Chandrakant, he dealt with renal cell carcinoma. So in operable clear cell renal cell carcinoma, there is a definite very strong data based on the Keynote 564 trial, wherein adjuvant pembrolizumab given for 1 year was found to result in significant improvement in intermediate or high risk operable clear cell RCC. However, this is labeled as optional, and the patients do need to be counseled that the OS data is still immature and there is potential for long-term adverse effects. Coming to metastatic clear cell RCC, the COSMIC trial, the triplet therapy in COSMIC trial, the results are impressive. However, they do come at cost of significant toxicity. He also dealt with newer agents, anti-VEGF, found to increase the HIF2 concentration, opening up the possibility of combining VEGF with HIF2 inhibition in favorable risk RCC, which is VEGF-driven disease entity. He subsequently went on to deal with the non-clear cell metastatic RCC, wherein pembro with lenvatinib does seem to work quite well. Lastly, he presented the data on first-line treatment for metastatic urothelial cancer, the patients who are unfit for cisplatin, and the combination of enfortumab vedotin with pembrolizumab did lead to impressive disease control rates to the tune of 93%, with duration of response being almost 25.6 months. So quite impressive data, a lot of active research ongoing, very impressive results, newer drugs showing impressive results, and a lot more action likely to happen in near future. So I would close my remarks here, and thank you, Dr. Ved, for giving me this opportunity. Thank you, Rajesh ji.
Thank you very much, madam. Gagar mein sagar. So,
but excellent masterclass today, I think, in terms of content and presentations.
Yes, madam. Very much power-packed and challenging to absorb all of it.
Yes.
Sir, would you like to add some comments for as take-home message for how we implement in India?
Definitely, Rajesh. After these wonderful presentations, Tanmay, Chandrakant, and Saurav, amazing presentations, and great learning experience for me as well. And Chandrakant, I can't agree more with you when you said that you don't read for a month. You feel you have lost the race, actually. And not a month. I feel if you don't read almost on a daily basis, I think, and if you have to practice general medical oncology, then it's going to be a disaster. Actually, it's changing so soon, so much. So it's been a great learning experience. Many thanks to all the presenters. Clear messages, Dr. Jyoti, for summarizing all that. And as I said, an amazing learning experience. All the faculty. Participants, we had 125 just a short while back, more than 350 registrations. My sincere thanks to each one who found time this evening to connect with us. Om Mishra from Samarth. Om, I have to thank you for conceptualizing this and the series of these master classes. We have seen the impact today, and then we continue to do the good work. And hopefully the next master class should come soon enough in the month of November as well, and December also.
It's already decided, and it's always a delight to have you. And I also learn a lot. And it's a platform where you provide to young practitioners, budding oncologists, upcoming doctors, and the students who are benefited with this. And I have already discussed with Rajesh. So very soon there are impact master classes going to be organized, and we'll always have to be there and under your guidance, under your leadership, and under your experience.
No, I think it's more collaborative, and I think this is the first time we have shared dice, not literally out here, but on the virtual platform with all these faculties, and they have done a great job, and we look forward to more such interactions. Rajesh, you and your team, Nirav, great support, very timely communications, and clarity of those communications. With that, I'll stop here. Everyone, take care. Have a great month ahead. Lot of festivities. My regards to everyone, to you and your families. Stay safe. Take care. Enjoy well. Thank you so much.
Thank you, sir.
sir,
I
and
wanted to
wish you
thank
all-
Swayamdeep also, colleague of Om, who has been
Okay.
working
Oh,
on the
my
back end.
apologies. My apologies. I missed out. Om, if you have anything to add. Thank you so much.
Nahi, sir, thank you for Dr. Chandrakant and Dr. Saurav, who have taken out their time in this festive mood, which Dr. Chandrakant was mentioning. And with this, we wish you a very happy Durga Puja in West Bengal. And happy Dashera to everyone, which will be coming very soon. Thank you very much, sir. Thank you, sir.
Bye. Good night.
Thank you, sir. Thank you.
Good night.
Rajesh, are you there?
Yes, sir.
बाद में बात करता हूँ राजेश.
Okay.